everyone, welcome to today's live stream. It's our first webinar of 2024, so I'm very excited to welcome you all. Please do get involved in the comments, say hi if you're watching live, and feel free to pop any questions for our speakers in the comments there as well. My name is Zoe, I'm a Programme Manager here at NAS, and I'll be hosting today's live stream. And today I'm joined by Dr. Kate Duhig and Kimme Hyrich, and Professor Kimme Hyrich. So hi to both of you, thank you for joining us.
Hi, nice to be here.
And if you're happy to, if you can each just introduce yourself to our viewers, that would be great.
Yeah, so I'm Kimme Hyrich. I'm a rheumatologist at Manchester Royal Infirmary, and I'm also an epidemiologist. And my research interest is around, in particular, the safety of biologic drugs.
Hi everyone, my name's Dr. Kate Duhig. I'm an academic obstetrician based at the Manchester Royal Infirmary and at the University of Manchester. My research interest is in complex medical disorders in pregnancy.
And yeah, we're really excited to have you both talking with us today because it's a very interesting but also really important area to be discussing as well. And it's something we get a lot of questions about. So it'll be great to have you with us to present on sort of general research and things like that, and also answer questions and importantly, share ways that people watching can get involved with research as well. So thank you both for joining us. So yeah, for anyone watching, please do pop any questions or comments in the comments box, and we'll have some time after a short presentation to answer any of your questions. So Kimme, if you're ready, I can hand over to you to present, and then we can come back and have a chat.
Perfect. So thanks again. What I'd really like to talk about today is an area that has recently had some update to the guidelines for how we should manage, particularly in pregnancy. And this relates to the use of biologic medications. And many of these biologic medications are used very successfully for the treatment of axial SpA. So you've already had some introductions from me and Kate, and I think it's a really nice area where the collaboration between rheumatology and obstetrics is really key because when a woman becomes pregnant, it's really a joint management between obstetrics and rheumatology that really ensure a successful pregnancy. So what Kate and I are going to talk about for the next short while are to give you some information about what we do know about biologics and other DMARDs in pregnancy. I'm going to review the guidelines that have recently been published about the use of these drugs in pregnancy. And then we're going to talk to you about a new clinical trial that we're hoping to start later this year that will answer, hopefully, some of the unaddressed and unmet questions that we still have in this area. So just so it's clear that when I say biologic therapies, I'd like you to know exactly what I'm talking about. So biologic therapies are a type of therapies that we use very commonly in rheumatology, and they work by either increasing or in sometimes decreasing the immune response. So the most classic examples are the anti-TNF biologic drugs, such as adalimumab, Amjevita is a good example, or etanercept. But also, and quite exciting for the management of axial SpA, is the introduction of some newer therapies, such as the IL-17 inhibitors, so secukinumab or Cosentyx is a classic example. So unlike the way we used to treat arthritis, often with just NSAIDs and occasionally other immune-suppressing drugs, biologic therapies are very different. They're different because they're engineered to be very precise and very specific and only target a very specific aspect of the immune system. This allows us often to have much better control about the effects of these drugs. The way they are made is through, in laboratories, they're engineered to look almost the same as our own natural antibodies. And just to remind you, antibodies, we all have them, and our bodies generate them often to defend off foreign things such as infections. So we have lots of them in our body. And so we need to take into account the fact that biologics are also antibodies, And because of that, they often act very similar to our own natural antibodies during pregnancy. So one of the most important things present when we become pregnant is the placenta. And the placenta plays a big role in controlling what passes into the baby. So there's many different types of drugs, and many of them can pass across from the mother who's taking the drug into the baby. And it's important to understand for the different medications how this happens. So some drugs will just pass freely through the placenta. This is called passive diffusion. Biologics do not do this. Instead, biologics, because they're large antibodies, have to be carried across the placenta into the baby. So we know that this does not happen until at least into the second trimester of pregnancy, and mostly happens in the third trimester of pregnancy. So this is very reassuring because most baby development happens in the first 3 months of pregnancy and even earlier on. So therefore, we become less concerned about problems with these medications in pregnancies, such as birth defects, because the drug is not visible to the baby during that early time. So this is a graph, and I'll talk you through it, but this line up the middle is the point that a woman gives birth. The blue line is the mom's antibodies and how much can be measured inside the baby. So as you can see here, before the baby's born, it's actually only mom's antibodies that are in the baby. Once the baby's born, they start to make their own antibodies, mostly to protect against infections, and over time, the mom's antibodies go away. So this is very cleverly designed by our bodies, such that all of the protection that the mother has against infections gets transferred and protects the baby for the first few months of their life until they're able to do it themselves. It's important to know about this relationship because it also means that drugs that look like antibodies, such as biologics, will also be carried into the baby, and for many of our drugs are also present in the baby after they're born. So then we have to question, does this matter? So there's actually now been thousands and thousands of pregnancies reported in the literature across rheumatology diseases and other conditions that use these drugs. Now, traditionally, women with axial SpA, other conditions such as rheumatoid arthritis, psoriatic arthritis, have been told to stop the drug in the first or second trimester. However, some related diseases such as Crohn's disease or colitis can flare very badly in pregnancy, and therefore many women choose to continue their biologic drugs through the entire pregnancy. Luckily, many of their doctors have published this experience in the medical literature, and we can learn about it. So what do we know about women who have taken biologics in pregnancy? We know that there has been no increase in birth defects observed above what might naturally happen in the general population. We know that babies who have biologics in their bodies after birth, there's not been any concern about routine childhood vaccines. So these are the routine vaccines that children get 1 month, 2 months, etc. Polio, tetanus, for example. Now, there is some concern about something we call a live vaccination. Live vaccinations are very different from the routine childhood vaccines in that they do contain versions of the actual infection we're trying to protect. And the one major live vaccine that we use in some women is the tuberculosis vaccine. And there's been some reports, very rare, but some reports of women whose babies have actually developed tuberculosis after the vaccination. So we now aim very carefully to avoid this vaccination in women. The other vaccines are safe. We also know that very little biologic drug passes into breast milk, and it's now advised that it is okay for women who choose to restart their biologic if they've stopped it during pregnancy to continue to breastfeed. So as I said, very recently, in fact, this was just published in 2023, based on the increasing amount of information we have about biologic drugs. New guidelines for the British Rheumatology Society, which covers all of the rheumatology doctors and all of the rheumatology nurses who are working within the NHS. And they've given us some very clear guidance now on how to use biologics in pregnancy. The first thing that the guidelines published was this guiding principle. It says that in all decisions regarding medication choice and changes, it's important to consider both the potential for deterioration in the mother's well-being through side effects or the reduced disease control in particular, and the adverse impact of that on their baby, balanced against the risk of any treatments in the baby. So there's a lot of guidance that's been published across a majority of drugs that we use in rheumatology, and I'm going to take you through this very briefly. So this first part of the guidance refers to many medications that for patients with Axial SpA are rarely used. So for example, there are some patients with Axial SpA that may be receiving medications such as methotrexate or sulfasalazine because they have arthritis in joints and involvement outside of the spine. We know that methotrexate has to be stopped prior to pregnancy, but other drugs need to be considered on an individual basis. Now, because these are not used as commonly in Axial SpA, I'd really like to focus instead on the biologic drugs. So the first group of medication that's considered within this guideline are the anti-TNF medications. You'll know that we have many, many different anti-TNF medications, and helpfully the guidance is the same for all of them, which says that it is safe to continue at the time of conception into the first trimester, to continue it throughout the pregnancy should a woman choose to do that, and during breastfeeding. And it's also okay if a father is receiving these drugs and wants to have a baby. There are some slight indications here for women that are taking it through the pregnancy, and these all relate to whether or not there are plans to give the baby a tuberculosis vaccine. We know a little bit less about the other biologic therapies, such as the interleukin-17 inhibitors, such as secukinumab. We have, based on somewhat more limited experience, the same feeling that the drugs will be the same in pregnancy as they are for anti-TNF medications. The reason there is some suggestion that some women may choose to stop these drugs is the drugs have simply just not been around long enough for us to have the same experience as the anti-TNF, even though to date there has been no concerns raised about these medicines. The only medication that we have in this category some major concerns about are the new JAK inhibitors. So these are drugs such as Xeljanz, Olumiant, which some patients, these are oral tablets, not injections. And because we know that these drugs will pass across the placenta, even in the first trimester, we recommend that they are not compatible with pregnancy. So for any woman or person who's planning a pregnancy, there's some general considerations that we should consider. The first is that where possible, it's always a good idea to have this discussion in advance of becoming pregnant with your rheumatologist or your rheumatology nurse. They can advise, in particular, whether there's any medications that you're receiving that should be stopped prior to conception. If there are any drugs that you need to continue to take, but we know that these are not a good choice in pregnancy, we can give time to switch these onto medications that are okay to take in pregnancy. And in general, all biologic DMARDs can be continued throughout pregnancy if they're required. The routine childhood immunizations are okay to give in newborn babies, but if there are special vaccines such as tuberculosis that need to be given, this needs to be very carefully considered. There's also the option still that we don't know whether all women need to continue their biologics during pregnancy. And some women will choose to stop them and they're okay. And in the next part of this talk, we're going to talk more about a clinical trial that we're planning to try to address whether this is in fact the best thing for women to do. And then finally, to reassure any men receiving these biologics who want to start a family with their partners that based on all of the information we have, it's perfectly safe for men to remain on their biologic therapy throughout this period. So at this point, I'm going to thank you for your attention, and I'm going to hand to my colleague, Kate, who's going to take you through the new upcoming MAMA trial.
Thanks, Kimme. And it's lovely to be here today to talk to you about this really exciting piece of research that we're planning, which should be coming towards the end of this year. So we're going to discuss the MAMA trial. MAMA stands for monoclonal antibody medications in inflammatory arthritis trial in pregnancy. Kimme, would you mind advancing the slides, please? So MAMA seeks to address this evidence gap in how we should best treat women with inflammatory arthritis who are pregnant. And MAMA is going to look at all types of inflammatory arthritis, including rheumatoid, psoriatic, AxSpA and JIA. And we know that up to 25% of the population do use biologic therapies. And because these drugs are so effective, many more women affected are now considering getting pregnant and having a family. And it's brought about much greater improved disease control. What we know is that if you have inflammatory arthritis and you get pregnant and your arthritis is poorly controlled, that in itself is associated with worse pregnancy outcomes. So it's really important that we're monitoring and controlling the disease well to ensure that the pregnancy is healthy. Kimme's covered much of this, but one of our concerns as obstetricians is that if we stop all of the medications in pregnancy, that women are at high risk of having a disease flare. And when you have a disease flare, as you'll know, many people end up on steroids or taking anti-inflammatory medications. And both of those can have a well-known negative impact on pregnancy. So high-dose steroids are associated with developing gestational diabetes, and certain anti-inflammatory medications also can't be used in pregnancy. So when we were thinking about this research question, we did a national survey to try and find out what rheumatologists are doing on the ground. And only 8% routinely continue biologics, except for this medication called Cimzia or certolizumab, where 68% of rheumatologists felt confident about continuing that medication throughout pregnancy. And this is despite overwhelming evidence of safety data. And doctors are more guarded about prescribing these newer generation drugs, as Kimme mentioned. But in other specialties, there is much more liberal prescribing. And as Kimme said, our gastroenterology colleagues are very commonly continuing women right throughout their pregnancy on these medications. We did a lot of work with women who had been pregnant or were planning pregnancies when we were trying to design our research. And I just wanted to share a few quotes really about a lady with rheumatoid arthritis talking about managing her RA being like walking on a tightrope. And when she finally found a combination of medication outside of pregnancy that was suitable and kept her disease under control, she was then really worried about becoming pregnant. How would she respond if she came off the biologics? If she went back on them, would they ever work the same again? And parents spoke overwhelmingly about feeling guilty about were they prioritizing their own health above the health of their babies. So there's a very real research need in this area. So the MAMA trial is a trial which is going to address this. And the question for MAMA is, does continuing biologics compared to stopping before the 3rd trimester, so before that end 3 months of pregnancy, results in lower arthritis disease activity during and up to 6 months post-pregnancy. And it's really important to capture what happens in that early period of your baby being born. Many women are at high risk of having a disease flare during that time. And poorly controlled arthritis activity obviously can have significant impacts on your ability to care for yourself and your baby. So the objective of the trial is to look at the peak arthritis disease activity from when women come into the study up to 6 months by a self-reported disease activity score known as RAPID-3. And we're going to look at secondary outcomes, which is impact on the pregnancy, and the baby, and then the child in its infancy and up to 24 months of age. We're going to recruit 328 women with inflammatory arthritis at less than 28 weeks gestation of pregnancy. And in women who give us consent, they will be randomly allocated to either continue their biologic throughout the pregnancy or to stop it before they become that 28-week time, so before that end 3 months of pregnancy, and to restart no earlier than 2 weeks after their baby is born. And this is going to take place in 35 obstetric units right across the country. Another quote from a lady that struck us particularly during developing the idea for the trial, and the design of the trial was about this risk of steroid use and how important it is that women are properly counselled, which brings back Kimme's point about importance of preconceptual counselling, and really understanding the risks of stopping their medications. We had a lady who talked about becoming very unwell as a result of side effects of steroids, and how difficult it was for her during her postnatal period to breastfeed her baby because of issues with her joints. So in our trial, we're going to ask patients to download an app, which I'll come on to, and report the RAPID-3 score, which is a score that looks at function, pain, and an overall health assessment. So women will answer simple questions about how are they able to complete certain activities. And then it also asks about their pain score. Sorry, Kimme, next. Thank you. And a global score as to how their condition is affecting them. And this will be collected at certain time points throughout the study, but with the option that patients can log into the app at any time and tell us how they're feeling that day, or if they feel like they're having a flare or they feel particularly bad, they can just log into the app and self-report this score. I think I've just covered that. Thank you. Yeah, and our feedback was that it's a very simple and easy scale to report. Women spoke of being very anxious in pregnancy and wanting to communicate how their arthritis was behaving during their pregnancy, but also that the score captured things that they found really difficult, like doing poppers on baby grows, or moving their baby into a position to breastfeed them. The score was quite inclusive of things that they found difficult. And the option to report these smaller flares was important because they found that they might not necessarily reach out to their rheumatologist to tell us about a very bad flare, but these smaller flares really did impact on their daily life. So the ability to self-report was really important. And this is where I'm going to come in and ask if there's anyone in the audience who might be able to help us, because we're developing lots of materials for use in our trial. We're working with a team of app developers, and we need patient and participant input to help test the app. And we're always looking for issues to support, alternative ways to support families because of problems with digital poverty and people having to, smartphones are expensive, and how we can support families so that it's not a barrier to taking part in our research. We'll be collecting important information about pregnancy outcomes. So any babies born early, do women develop serious infections in both sides of the study? And we'll be following up the babies and children, looking at early infections in the baby and whether the babies go to the special care baby unit. And we'll be following up the children until they're 2. At 2 years old, children undergo a global assessment of their development, and we're going to be collecting those developmental scores, again, in both sides of the study, to ensure there are no differences. There is a sub-study that will be going on where some babies who are born to women who've been in the study will be followed up with a blood test to look at how their immune system behaves. How are they responding to their routine childhood vaccinations? Is that as we expect? And that will give us some really fantastic data about babies' immunity, with which we're hoping can reassure parents in future. So we'd be delighted to hear from anyone who would like to support us and to be involved. This could be for really small amounts of time, like reviewing bits of information to be included in the study. And some women have indicated they'd like to give us larger amounts of their time, which would be fantastic. All of your time is financially compensated. Rates are set by the charities that we work with. So nobody will be out of pocket for any time that they would like to contribute to us. So we'd love to hear from you. The email address is mama@npeu.ox.ac.uk. Thank you. That's it, Kimme.
Wonderful. Thank you both so much. I just remembered to unmute my microphone there. That was fantastic. That was really information-packed presentation. So thank you both so much. And it's such an important area for so many people as well. And it was really great to touch on medication and men with fertility as well. So that was really helpful to include. Thank you. So we've got a couple of questions coming in, and we've also got some questions that were sent in before the live. So for anybody watching, if you do have any questions, now's your time to pop them in the chat, and we'll cover as many as we can before we finish up. So I popped a little note there. So it would be great, firstly, to ask how an axial SpA pregnancy might be different from kind of a normal pregnancy, and any kind of additional precautions that should be taken. Do you know who would like to take that?
Yeah, I mean, in general, the pregnancy itself physiologically should not be any different from a pregnancy in someone who doesn't have axial SpA. But there's all those other considerations. There's the consideration, of course, about the medication, which we've just talked about. There is the considerations, and we're hoping it might be one question this trial addresses, is whether it's better to stay on the medication to maintain control of your spinal symptoms and the stiffness and the fatigue and the pain, because in pregnancy, back pain can be a problem anyways, and we don't necessarily want that exacerbated. And Kate, you're the one that usually receives the woman when they're in labor. Would you have anything else to add to that?
No, only that for patients with medical who get pregnant, have a medical condition in pregnancy, they should be cared for in a maternal medicine clinic. So they should be referred to their local maternal medicine service. So seeing an obstetrician who is used to caring for patients who have arthritis conditions. In women who are on a biologic who are pregnant, they are referred to a regional centre. So they're under the care of an even more kind of specialised team of obstetricians and medical doctors. Often in specialist joint clinics, there'll be a joint clinic where you would come along and see your obstetrician and your rheumatologist, and have a sort of tertiary level care setting. You may still have your baby in your local unit, but often those teams are around for advice, or if you have a flare, just having the opportunity to get into that clinic very quickly, to be sort of seen on an expedited basis if you're struggling with your disease.
That's really helpful, thank you. And a little bit more of a general question again, in terms of managing axial SpA during pregnancy. Someone asked if it's safe to exercise with weights and high intensity training at the gym throughout pregnancy. I understand that might be quite specific to an individual.
Absolutely, exercise is encouraged in pregnancy. We would probably say don't take up these activities if you've never done them before, but certainly if you're fit. The Royal College of Obstetricians and Gynecologists has some great advice about exercise in pregnancy and about staying mobile and active. All of that is, and generally your body will tell you what you're limited by. Certain exercises are really great, like swimming and lower impact things, but you know, high intensity exercises is not bad, especially if you're somebody who is used to that level of activity. So yeah, be healthy.
Perfect. We can always share a link to those resources in the comments afterwards as well, if anybody wants a bit more info. Moving on to some medication questions. So firstly, about the non-steroidal anti-inflammatory medications. So someone asked both in terms of whether it affects your chances of conceiving if you're taking them, and also how you can manage pain during axial SpA without taking the NSAIDs.
Kimme, do you want to?
So I'm not aware about any association with fertility, but there are periods during pregnancy where NSAIDs would not be advised for women. So management of pain is tricky, and as a rheumatologist, I will say that we don't always have good suggestions. So with women that are experiencing pain in pregnancy, there's very good access to physiotherapy services through obstetric units, often quicker to access if you're not already engaged with a rheumatology physiotherapy department. And then all of those tricks that people might have used themselves to try to alleviate pain that don't require medication per se can also be used.
Perfect, thank you. And I can add a link to the comments. We've got some sections on our website on kind of non-medication pain relief that we can signpost to as well. Wonderful. So we've had a question about biologics. I'll pop it up on the screen for everyone to see. But Maria's asked if it's possible to stop the biological treatment before getting pregnant, and in case of flare-ups, start the medication again. Any thoughts on that?
So Maria, if you were my patient, I'd probably want to have a discussion with you about why you wanted to stop the biologic and what were your concerns. If you have that discussion with your rheumatology team, hopefully they have a good idea about you and your disease and what it's been like and how severe it was before biologic therapy. The one thing that I have learned personally, and I've shared the experience with many of my patients, is you cannot predict when you'll become pregnant. And that period off the drugs can actually turn out to be a very long time. And conception may become more, I don't want to say unpleasant, if you're very painful and having a lot of problems. So if you had any specific concerns about stopping it, probably that's a first thing to address. However, based on what we currently know about biologics, there wouldn't be a reason to restart the biologic during pregnancy. Because the fact that you weren't already taking it in the first or second trimester doesn't mean it wouldn't have the benefits if you were to restart it later on.
Oh, that's reassuring. Thank you. Wonderful. And we've also got a question asking about the likelihood of inheriting. So if a parent has axial SpA, what the likelihood is that the child will inherit it?
So this is a really common question from many women who have chronic diseases. And so the first thing to say is we don't know exactly what causes AxSpA. So we know there is a genetic tendency, particularly with one gene called HLA-B27, although we know there's many genes that are associated with it. But what we also know is not everyone with HLA-B27 gene that they may have inherited from their parents develops AxSpA. So based on what we currently know, if you carry the HLA-B27 gene, we know there's 50% chance that your baby may inherit it. That's just the way inheritance works. But if they did inherit it, it may only be a 5 to 10% chance that they develop AxSpA. That's if you're an HLA-B27. If you have one of these other genetic risks that we understand less well, the chance may be even lower. So the majority of children who have a parent with AxSpA don't develop AxSpA, although the risk is higher than if your parent did not have AxSpA. Does that make sense?
Absolutely. And that's really reassuring, because we do hear from people who are worried about having children because they have the condition. So hopefully that all puts some minds at rest as well.
Yeah. I mean, no one would wish an illness on their child. We are, in addition to studying the long-term safety of biologic drugs in adults, we're also studying them in children. And there's some very reassuring data that, should we need to treat children for these conditions, we would wish no one to have any of these conditions, but these drugs are very effective as well.
Oh, that's great. That's a very positive note to end on, I think, unless either of you have any final thoughts that you wanted to add to that.
No, just to thank you again for allowing us to come and speak to you, and we're looking forward to starting our trial later this year.
Yeah, I think that's going to have some really valuable insights for people, as very needed research as well. So for everyone who's watching, we will share more details about the trial, more information about how you can get involved. I'll put a link in the comments with the email address if you want to get in contact, but we'll also share as well through our e-newsletter. So do sign up to that if you want to hear a little bit more. So wonderful. Thank you both so much for your time today. It's been fantastic. And thank you everyone for joining and watching. And it was lovely to see a comment from Jane there that although she doesn't have children, she's found it really interesting to sort of have, hear about it and hear about the study as well. So thank you very much. Wonderful. So we'll let everyone know about our upcoming live webinar in the next few weeks, and hopefully see you then. But thank you both, and take care, everyone.